Our third and final mental health lecture is going to be on insomnia. If you haven't already, please watch the depression and anxiety lectures prior to watching this one. By the end of this presentation, you should be able to compare and contrast the significant adverse effects associated with the benzodiazepines, non-benzodiazepine receptor agonists, ramelteon and suvorexant for patients with insomnia, select the most appropriate sedative hypnotic for a patient with insomnia based on the type of sleep disorder and the pharmacokinetic profiles of the medications, and finally, design a pharmacologic treatment plan for a patient with insomnia using patient-specific characteristics and preferences. There are several pharmacologic treatment options for insomnia, and we're going to primarily focus on the benzodiazepines, non-benzodiazepine receptor agonists, the melatonin receptor agonist, and our orexin receptor antagonist. We're not going to focus as much on the medications listed to the right, and that's because these are typically used later in treatment or for specific patient populations. Our sedating antidepressants like doxepin, amitriptyline, trazodone, and mirtazapine are alternatives for patients with depression or anxiety, or those who should not receive benzodiazepines, like those people with a history of substance use disorders. One thing to note is that our sedating antidepressants have not been well studied in those without depression, so they really should be reserved for patients with a history of depression or anxiety. We also have some sedating antiepileptics, but once again, these are usually reserved for later in treatment. Quetiapine and olanzapine are sedating antipsychotics, but like our sedating antidepressants, they should be reserved for patients with certain mental health disorders, and that's because these have pretty problematic adverse effect profiles. There are also some over-the-counter or herbal medications available. Our antihistamines like diphenhydramine and doxylamine are typically not recommended due to lack of safety and efficacy data for insomnia. Patients tend to quickly develop tolerance to the sedative effects of these medications, and they have anticholinergic side effects, which are those drying side effects. So you'll see things like dry mouth and constipation, and that can be especially problematic in our elderly patient population. They can also create a hangover effect the next day where patients tend to feel slow, lethargic, and not mentally as sharp. Melatonin is a naturally occurring hormone in our body that promotes sleep. There are some studies showing that it has mild sleep-promoting properties, and it has been found to decrease jet lag. And I would say that's probably one of the primary uses for melatonin, if you're going to base it on evidence, is for decreasing jet lag. It really has no established efficacy for chronic insomnia, and its long-term safety and efficacy have not been evaluated. And then finally, we have another herbal product, valerian root, and with this medication, once again, the long-term safety and efficacy have not been evaluated.
Listed here are the medications under each category of sedative hypnotics we'll be discussing today. We already talked about benzodiazepines in the anxiety disorder lecture, but you will see that we have different benzodiazepines listed on this slide, and that is because these are the agents FDA approved for treatment of insomnia. These medications are used interchangeably, so some of the benzodiazepines approved for treatment of anxiety are also used for the treatment of sleep. Another thing to note on this slide is that zolpidem is available in several different formulations, so there are several different brand names. Most people are familiar with Ambien. Ambien CR is the controlled release form. Intermezzo is a sublingual, low-dose, long-acting form of zolpidem that is approved for people who wake up in the middle of the night and can't fall back asleep. Edluar is a sublingual formulation, and Zolpamist is an oral spray. Of the melatonin receptor agonists, we will focus on ramelteon. Tazimelteon is approved for non-24-hour sleep-wake disorder, which is a circadian rhythm disorder affecting individuals who are blind. Therefore, it has a very specific role in therapy and isn't used in the general patient population. This lecture is focused on pharmacologic therapy, but as you can see, non-pharmacologic behavioral interventions are the first-line treatment option for insomnia. Some of our non-pharmacologic approaches include things like cognitive behavioral therapy, stimulus control therapy, relaxation therapy, and sleep hygiene. So, although we're not going to talk about these things, I really want to emphasize the importance of them. And oftentimes in clinical practice, we see people jump right to medications when really medication is recommended as second line, and even as second line, the evidence for it is weak compared to our non pharmacologic interventions. So, you just really want to make sure that patients are doing everything they can from a non pharmacologic perspective before adding medications. The type of medication that we use is going to depend on the type of insomnia that the patient has. So, for example, are they having trouble falling asleep or staying asleep? And then there are several medications listed on this slide for which use is not recommended for the treatment of insomnia, and that's typically due to lack of safety and efficacy data.
There are some general guidelines to be aware of when prescribing sleep medications. And again, we want to first address any behaviors, circumstances, and underlying disorders that may be contributing to insomnia. There are many medications that can cause insomnia, and some of them are pretty easy to access, something over the counter like Sudafed or pseudoephedrine. We also have talked about mental health medications like fluoxetine or bupropion that can cause insomnia. There are many examples, so always make sure to review a patient's medication list before just adding on a medication for sleep. Also making sure that you're addressing any behaviors. Are they drinking caffeine or smoking cigarettes right before bed? Are they watching TV or playing video games in bed? Try to address all of those things and fix them before prescribing a medication. If you are going to prescribe a medication, you should try to prescribe the lowest effective dose and use it for a short duration, ideally just 2 to 4 weeks or intermittently. Be aware of requests for escalating doses or patients who are resistant to tapering or discontinuing sleep medications, as this may be a sign of a different problem. And then when you discontinue the medication, make sure to discontinue it gradually or slowly taper the medications. The benzodiazepines and NBRAs have the same mechanism of action but are unrelated. Both of these medications bind to GABA receptors and induce sleepiness. Our melatonin receptor agonists bind to melatonin 1 and 2 receptors. The melatonin receptor 1 regulates sleepiness, and melatonin receptor 2 regulates phase shifts from day to night. And then our orexin receptor antagonists block orexin 1 and 2 receptors. Orexin is a chemical in our body that promotes wakefulness, so this medication binds to orexin receptors and blocks those receptors, and so it's no longer able to promote wakefulness. The kinetics associated with these medications can be a bit complex or confusing, but it's important to have a good understanding of the kinetics because this is ultimately what will help you select a specific agent for a patient depending on the type of sleep disorder they have. With onset and duration, you'll notice that rather than giving you a bunch of different numbers, I tried to summarize it verbally. And it's important to note that depending on the reference or guideline that you're using, this information can vary slightly. So this is just a general guideline. Some things, if you look up an agent specifically, you might find a little bit different information, but for the purpose of this lecture, this is how we're going to categorize these drugs. So let's just look at our benzodiazepines to start with. You'll notice that triazolam is the only one that has a short duration, so a fast onset and a short duration, and it's therefore used more often for sleep onset, so difficulty falling asleep. While the other benzodiazepines have long or intermediate durations, making them more appropriate for sleep maintenance, those that have trouble staying asleep. You'll also notice that the half-life of these agents can really vary, so agents like lorazepam and clozapam have a very long half-life and are generally not used in our elderly patients due to those long half-lives and their active metabolites. This can lead to potential accumulation and daytime hangover. Another thing to note is that there are differences in how they're metabolized. We covered this quite a bit in the anxiety lecture, so I'm just going to touch on it briefly. This time temazepam is our only benzodiazepine that undergoes conjugation rather than hepatic oxidation. So just like how we use the razepam and oxazepam preferentially in those with liver dysfunction or in the elderly, we would pick temazepam if we had an elderly patient requiring a benzodiazepine for insomnia or if someone had liver dysfunction. We also have our non-benzodiazepine receptor agonists, and they can differ in their durations as well. And then zolpidem varies according to the product. I didn't list the half-lives for zolpidem because they once again vary according to the product, and you can look that up in Micromedics or Lexicomp. And then we'll discuss their primary uses more specifically when we delve more into the non-benzodiazepine receptor agonists. You are not required to memorize dosing, but there are a few things I'd like to point out on this slide. Listed here are the usual dose ranges of the medications, as well as the maximum recommended dose for geriatric patients. Flurazepam and clozapam are not recommended for use in the elderly, but I included dosing just in case you see them used. And then there are no dose adjustments for geriatric patients for Ramelteon or suvorexant, so neither of those products list dose adjustments at this time. If you look at zolpidem, you'll notice that the maximum dose depends on whether you're male or female. And the FDA actually came out and required a lower dose for women due to some data that showed that blood levels in some patients was high enough the morning after use to impair activities that required alertness, such as driving. The FDA recommends, but does not require, lower dosing for men as well. So just be aware that you can't use the same max dose in women that you can for men for the zolpidem products.
We already reviewed the adverse effects associated with the benzodiazepines in the anxiety disorder lecture, so please refer to that lecture for a discussion of the adverse effects. The NBRAs are associated with things like headache, dizziness, and upset stomach. Eszopiclone is unique in that it is associated with an unpleasant taste and dry mouth. Of the products listed here, Ramelteon is typically the best tolerated. The adverse effects listed are similar to the NBRAs, but the incidence is typically lower. Suvorexant and lemborexant are associated with daytime somnolence and next-day driving impairment. The sleep paralysis, hypnagogic and hypnopompic hallucinations, and cataplexy-like symptoms are dose-dependent. Hypnagogic hallucinations occur during the transition from wakefulness to sleep, and hypnopompic are the opposite in that they occur during the transition from sleep to wakefulness. There are warnings and precautions that accompany all sedative hypnotics. The first is that all of them have a warning for severe anaphylactic reactions. They all have warnings for complex sleep behaviors that can present in a variety of ways. I have several listed here. They can potentially be dangerous, so things like sleep driving, sometimes sleepwalking. These are most often associated with the NBRAs, but could potentially happen with any sedative hypnotic. That being said, this is rare. They also all have a warning for worsening of depression and suicidal ideation, so make sure to monitor for this. And there is an increased effect when combined with alcohol or other CNS depressants. And so patients should avoid alcohol whenever they're taking a sedative hypnotic, and this is especially important if they're taking something like a benzodiazepine or an NBRA.
There are some special considerations to think about when using the benzodiazepines for insomnia rather than anxiety. They do work to reduce sleep latency, which is the time that it takes to transition from wakefulness to sleep, and they also increase total sleep time. As mentioned, they differ in their kinetic profiles, and we can use these kinetic profiles to help select the most appropriate agent for a patient depending on the type of sleep issue they're having. We want to ideally use benzodiazepines for brief periods of time, and that's usually just 7 to 10 days, but clinically speaking, you will see them used for longer periods of time in practice. And one of the reasons that we want to use them for just 7 to 10 days is that tolerance and dependence can develop. Tolerance occurs when a benzodiazepine just stops helping the patient with sleep. versus dependence is when a patient may have worse insomnia if they do not take the benzodiazepine. Tolerance to sleep typically develops after about 4 weeks of use, where dependence can develop after 2 to 4 months of daily use with the longer acting agents, or within days to weeks with shorter acting agents. The benzodiazepines can be used on an as needed basis for insomnia. This is different from anxiety, where we want to take them on a scheduled basis. These medications can also cause rebound insomnia and next day impairment. We especially want to make sure patients don't abruptly discontinue the medications, because that abrupt discontinuation can lead to the rebound insomnia, and that is defined as insomnia that was worse than before, as well as having usually nervousness and jitteriness. Next day impairment is more likely in agents that have a long half-life, while rebound is more likely in agents with a short half-life. We also want to use caution in patients with respiratory disorders and avoid them in patients with sleep apnea, because these medications can reduce upper airway muscle tone and worsen apneas. Once again, we should avoid these medications in patients who have a history of substance use disorders, who are pregnant, or who are perhaps using alcohol or other CNS depressants. For the NBRAs, the effect on sleep varies depending on the product. As zopiclone has a longer duration of effect than either Zaloplan or Zolpidem. Zaloplan has a shorter half-life and is least likely of the products listed here to cause residual daytime sedation. Another kind of interesting thing about Zaloplan is that it can be taken in the middle of the night, as long as individuals have at least 4 hours left in bed, or at least 4 hours left to sleep. Zolpidem initiates sleep effectively and maintains sleep longer than Zaloplan for those with nocturnal awakenings. It also has many different formulations. The controlled release version of Zolpidem may allow for somewhat longer sleep compared with the immediate release formulation, but there are no comparative trials that have shown a distinct clinical advantage of the controlled release version over the immediate release version. So I actually have never recommended the controlled release formulation, just because it's so much more expensive. The intermezzo formulation of Zolpidem can also be used for those middle of the night awakenings, as long as a patient can have about 4 hours left for sleep. There are some advantages of using the NBRAs compared to the benzodiazepines. The NBRAs are less disruptive of the sleep stages. There's also a lower risk of abuse, withdrawal, tolerance, and next day impairment. So note that that does not say no risk, it just says lower risk. Abuse potential is lower but still problematic with the NBRAs, and just like with the benzodiazepines, you should not combine them with alcohol. It's also important to not abruptly discontinue them, because patients can experience withdrawal. They are effective for a longer period of time. Depending on the product, they have been studied or found effective for up to 3 to 6 months of therapy. And just note that they do not have any anxiolytic effect compared to the benzodiazepines. We once again need to use caution in patients with respiratory disorders or sleep apnea, and these products should be taken on an empty stomach, because it allows for faster absorption of the medication. Ramelteon reduces sleep latency, so it's best for patients who have difficulty falling asleep. It is not a controlled substance, and there's really no risk for rebound insomnia, withdrawal, abuse potential, or tolerance. So this is a good medication for patients with a history of substance use disorders or substance abuse. There's also little to no risk of next day impairment, and it's safer to use in patients with respiratory disorders or sleep apnea. Now, it's important to know that no sleep medication is recommended in patients with respiratory disorders or sleep apnea, but if you're going to select one, this one has a safer adverse effect profile in this patient population. Efficacy for this medication has been supported for up to 6 months of continuous use.
Our orexin receptor antagonists reduce sleep latency and increase total sleep time. One thing to note is that suvorexant is a Schedule IV controlled substance. There appears to be less abuse potential than with our benzodiazepines and NBRAs, but we still need to use caution. And then it appears that they're not associated with rebound insomnia or withdrawal symptoms. There are reports of these medications worsening depression and suicidal thoughts, so we need to use caution in the patient populations that we're selecting these medications for, and just a reminder that they do have a unique adverse effect profile. These medications can cause next day impairment, so patients should not take them unless they are able to stay in bed for at least 7 hours.
Non-pharmacologic approaches are always first line for insomnia, but this is especially true with our elderly patient population. It's really important to identify any underlying causes for sleep complaints, and this could be anything from medical illness, changes in sleep environment, medications, or stressors. Cognitive behavioral therapy is an effective and safe alternative to drug therapy, and you may want to consider this if you have an elderly patient. There are many advantages with CBT, and this is just avoidance of medications and all their associated adverse effects and drug interactions. Some possible disadvantages are that it can take longer to achieve an effect. There may be higher initial costs associated with it. It's definitely more time consuming and not always widely available due to a lack of trained providers in many areas. We should avoid the sedating antihistamines due to their anticholinergic side effects and lack of evidence. Patients will also develop tolerance to the antihistamines within about 3 to 7 days. We also want to avoid benzodiazepines in this patient population for all the same reasons that we wanted to avoid them in elderly patients with anxiety. If we are going to use a benzodiazepine, temazepam would be preferred. If you're going to use medications off-label, you could also consider lorazepam or oxazepam. The NBRAs have similar adverse effects to the benzodiazepines. If you're going to use one, agents with shorter half-lives like zolpidem or zaloplan are preferred, and you should use them for the shortest duration possible. Of our prescription medications, Ramelteon has typically the best safety profile and may be most appropriate to start with in our elderly patient population. And then with all our medications, make sure to start with a low dose and titrate slowly. We will also want to start with non-pharmacologic behavioral interventions for our pediatric patient population. And this can be pretty simple, such as having consistent bedtimes and wake-up times and making sure that they have a consistent bedtime ritual. There is no FDA-approved sedative hypnotic for children or adolescents. Diphenhydramine, melatonin, and clonidine are most commonly prescribed if medications are used. Diphenhydramine can have a paradoxical effect in children in that it can actually make them a little bit hyperactive, so you have to be careful about that. We also have concern about those anticholinergic side effects, and there's potential for next day hangover, which can be problematic if kids have to go to school. Melatonin has been studied in children and is well tolerated, so that's why you will see it used in children. And then clonidine is an antihypertensive that lacks data really to support safety or efficacy, but it is used because it's sedating. You need to be careful because side effects include things like dizziness, bradycardia, and hypotension. And this medication should not be abruptly discontinued because it can cause rebound hypertension. Use of NBRAs is increasing in this patient population, but is not recommended because it lacks clear therapeutic benefit. If you're going to use a medication, once again, start with low doses and use for the shortest duration possible.
For pregnant patients, we want to focus on good sleep hygiene and reducing fluid intake near bedtime, which can help reduce nocturia. Diphenhydramine is considered safest for use, and it should be taken on an as-needed basis rather than scheduled. However, this medication should be avoided during lactation because it can dry up the milk supply. Benzodiazepines were discussed during the anxiety disorder lecture, and for the purpose of insomnia, they should be avoided during pregnancy and lactation. You can consider the NBRAs if the potential benefits outweigh the risks. Most of our data is with zolpidem. Zaloplan and isoprolol don't have sufficient data in pregnancy to make recommendations. Zolpidem is associated with a lower birth weight and preterm delivery. Its use is considered compatible with lactation, but you should use caution. So you really need to have a risk-benefit discussion with the patient and help them come to a decision. We have less data with our other sedative hypnotics, so the risks are unknown and typically are not recommended for use during pregnancy.
This is an algorithm that can assist in helping select a medication. So if we look at the right side of the screen or the right side of the algorithm under difficulty falling asleep, there are several agents listed. Zaloplan, triazolam, and Ramelteon have rapid onsets and short duration, so that's why they work well for patients who are having trouble falling asleep. Zolpidem and isoprolol have rapid onsets but longer durations of action, which may be why they would work well for patients who are having difficulty maintaining sleep, as well as isoprolol and temazepam working well for patients who have early morning awakening. Temazepam has a long onset of action and an intermediate duration. As a reminder, Zaloplan and the intermezzo formulation of Zolpidem can be used for middle of the night awakenings as long as the patient can devote at least 4 hours to sleep. For patients with sleep apnea, it is recommended that you refer them to a sleep lab and confirm that they have sleep apnea and try doing other things to help, like CPAP, before using a medication. For patients with psychiatric disorders, this may be where you'd want to consider a sedating antidepressant if they have depression or anxiety, or perhaps a sedating antipsychotic if they have something like schizophrenia or maybe bipolar disorder. If you have a patient with a substance use disorder, we'll typically try to avoid things like the benzodiazepines and even the NBRAs.
The table on this slide is just meant to complement the chart on the previous slide. It's a little bit more comprehensive and that includes more medications. And this is just meant as a general guide. Of course, some of these things are used interchangeably. Many times patients will have more than one type of sleep problem. They may have difficulties falling asleep and staying asleep. So this is just meant as a general guide, although you'll see a variety of things done in practice.
In summary, we should assess for underlying causes of insomnia, and this can be things like alcohol, caffeine, or nicotine use, poor sleep hygiene, pain, or psychiatric disorders. Our non-pharmacologic interventions are always first line, and over-the-counter sleep medications are not recommended due to lack of safety and efficacy data. If you're going to use a benzodiazepine, you should try to use it at the lowest dose and shortest duration possible to help avoid tolerance and dependence. The selection of the benzodiazepine is going to depend on its kinetic profile and the type of sleep disorder that the patient has. We're going to want to avoid using them in patients with sleep apnea, substance use disorders, and the elderly. However, temazepam is preferred in the elderly and those with liver disease if you are going to use a benzodiazepine. The NBRAs offer many advantages over the benzodiazepine, but once again, selection of an agent depends on the type of sleep disorder that the patient has and the kinetic profile. Ramelteon is well tolerated and has a good safety profile. It's a great alternative for patients with substance use disorders. And finally, sedating psychiatric medication should be reserved for patients with psychiatric disorders.